A single cycle of the cardiac activity can be divided into two basic phases, diastole and systole. The cardiac muscle of the heart contract and relax in a rhythmic cycle. During the contraction phase, which is called systole, blood is propelled out of the ventricle and into either pulmonary or systemic circulation. During the relaxation phase, which is also called diastole, blood fills the emptied ventricles, and one complete heartbeat, a systole followed by a diastole, is considered a cardiac cycle. Now, the diastole represents a period of time when ventricles are relaxed when they are not contracting. Throughout most of this period, blood is passively flowing from the left atrium to the left ventricle and the right atrium into the right ventricle. The blood flows through atrioventricular valves, which are also called mitral and tricuspid valves, that separate the atria from the ventricle. The right atrium receives venous blood from the body through superior vena cava and inferior vena cava. Now, the left atrium receives oxygenated blood from the lungs and four pulmonary veins that enter left atrium. At the end of the diastole, both atria contract, which propels an additional amount of blood into the ventricles. Systole represents the time during which the left and the right ventricles contract and eject blood into the aorta and pulmonary artery. And during this systole, the aortic and pulmonary valves open to permit ejection into the aorta and pulmonary artery. The atrioventricular valves are closed during systole. Therefore, no blood is entering the ventricles. However, the blood continues to enter atria through the vena cava and the pulmonary veins. Now, here we have to discuss a few phases of how it happens. First phase is that when atrioventricular valves remain open and the semilunar valves remain closed. This is the first phase of the cardiac cycle. It is initiated by the P wave of the electrocardiogram, which represents the electrical depolarization of the atria. Now, the atrial depolarization initiates contraction of the atrial musculature. As the atria contract, the pressure within the atrial chamber increases, which forces more blood flow across the open atrioventricular valves, leading to a rapid flow of blood into the ventricles. The blood does not flow back in the vena cava because of inertial effect of venous return and because of the wave of contraction through the atria, which moves towards the AV valve, thereby having a milking effect. However, atrial contraction does produce a small increase in venous pressure that can be noted as an A wave of the left atrial pressure. Just following the peak of the A wave is the X descent. You are seeing this graph on the screen right now. It is the changes in the pressure while in a complete cardiac cycle. So before the atrial systole or atrial contraction begins, the ventricles are already 70% filled because of passive blood flow from the atria. The atrial contraction normally accounts for about 10% of left ventricular filling, and when a person is at rest, because most of ventricular filling occurs prior to the atrial contraction, as blood passively flows from the pulmonary veins into the left atrium, then into the left ventricle through the open mitral valve. At high rates, when there is less time for passive ventricular filling, the atrial contraction may occur for up to 40% of ventricular filling. This is sometimes referred to as atrial kick. The atrial contribution to the ventricular filling varies inversely with the duration of the ventricular diastole and directly with the atrial contractility, which means the longer the time it will take for the heart relaxation phase, the shorter will be the amount of contribution of the atrial contraction in filling up the ventricle. While in case of higher amount of demand of blood flow for the body, such as during exercise, the duration of the cardiac cycle shortens, so does the timing of the relaxation phase, which shortens with the increased heart rate and speed of heart contractility. As atrial contraction phase ends, ventricular systole and contraction begins. When the ventricles begin to contract, the ventricular pressure becomes greater than the atrial pressure. The atrial pressure begins to fall, causing a pressure gradient reversal across the AV valve, forcing closure of the AV valves. The chordae tendineae, which are anchoring the AV valves, ensure one-way blood flow by preventing the valve from opening into the atria, or in other words, preventing atrioventricular valves and collapsing back into the atria. This increase in pressure in the ventricles as compared to those in atria causes the valves to float upward into their previous position before the closure. At this time, the ventricular volumes are maximal, which is termed end diastolic volume. The left ventricular end diastolic volume, which is typically about 120 milliliter, represents the ventricular preload and is associated with the end diastolic pressure of 8 to 12 millimeters of mercury in the left ventricle and 3 to 6 millimeters of mercury in the right ventricle. Heart sound is sometimes noted during the atrial contraction, which can also be called as fourth heart sound. This sound is caused by the vibration of the ventricular wall during the atrial contraction when the blood is hitting the ventricular walls. Generally, it is noted when the ventricular compliance is reduced, or we can say the ventricles have become stiff and they are not elastic anymore. It happens in ventricular hypertrophy and in many older individuals. Now, when this phase has ended, now all the atrioventricular valves and the pulmonic and aortic valve have been closed as well. This phase of cardiac cycle begins with the appearance of the QRX complex of the ECG, which represents the ventricular depolarization, which actually is shown by contraction of ventricles. This triggers excitation, contraction, coupling, myocyte contraction, and rapid increase in intraventricular pressure. Early in this phase, the rate of pressure development becomes maximal. This is referred to as maximal change of pressure in comparison to change in time. The atrioventricular valve flows with intraventricular pressure which exceeds the atrial pressure. Ventricular contraction also triggers contraction of the papillary muscles with their chorda tendineae that are attached to the valve leaflets. This tension on the AV valve leaflets prevents them from bulging back into the atria and becoming incompetent or leaky. This we have discussed before about specifically with regards to the chorda tendineae. The closure of the AV valve results in the first heart sound, or S1, and this sound is normally split and has a duration around about 0.04 seconds. Because mitral valve closure actually precedes the tricuspid valve closure. During the time period between the closure of the AV valve and the opening of the aortic and pulmonary valve, for a brief period at beginning of the ventricular systole, aortic pressure is greater than the ventricular pressure and the ventricle cannot empty. So the ventricular pressure rises rapidly without a change in the ventricular volume, that is, that no ejection is happening and no valve has opened yet. The ventricular volume does not change because all the valves are closed at this phase. Contraction therefore is said to be isovolumic or isovolumetric, which means that isovolumic contraction or isovolumetric contraction. The individual myocyte contraction, however, is not necessarily isometric because individual myocytes are undergoing length changes. Some individual fibers contract isotonically, that is concentric shortening contraction or contraction around the circumference, because cardiac muscles in the ventricles are arranged in a spiral manner across the cardiac skeleton. Whereas there is also isometric contraction or contraction along the longitudinal length of the ventricle, that is, there will be no change in length, or eccentrically, that is lengthening contraction. Therefore, ventricular chambers geometrically changes considerably as the heart becomes more spheroid in shape. The circumference increases and the atrial base to apex length decreases. This rate of pressure increase in the ventricle is determined by the rate of contraction of the muscle fibers, which is determined by the mechanism governing the excitation contraction coupling. The maximum rate of pressure change during this phase is termed the dP over dt max, or change in pressure in comparison to the change in time. The C wave noted in the left atrial pressure may be due to bulging of mitral valve leaflets back into the left atrium. Just after the peak of the C wave is the X descent. Now the other phase starts with the aortic and pulmonic valves open and the atrioventricular valves remain closed. This phase represents initial and rapid ejection of blood into the aorta and the pulmonary arteries from the left and the right ventricles respectively. Ejection begins within the intraventricular pressures exceed the pressure within the aorta and the pulmonary artery, which causes the aortic and pulmonic valves to open. Blood is ejected because of the total energy of the blood within the ventricles have exceeded the total energy of blood within the aorta. In other words, there is energy gradient to propel blood into the aorta and the pulmonary artery from their respective ventricles. During this phase, the ventricular pressure normally exceeds outflow tract pressure by few millimeters of mercury. This pressure difference gradient across the valve is ordinarily low because of the relatively large valve opening, that is low resistance of the valves. The maximum outflow velocity is reached in initial early in the ejection phase, and the maximum systolic part is in the aortic and the pulmonary artery pressures are achieved. No heart sound are ordinarily noted during ejection because the opening of the healthy valves is silent. It's only during any disease the valves there can be no fluent flow of the blood across these particular valves, causing vibration of the blood while passing across a valve, leading to the presence of sound during ejection. These abnormal sounds are known as murmurs. Here it will be called systolic murmur, which indicates valve disease or intracardiac shunts. Left atrial pressure initially decreases as the atrial base is pulled downwards due to extensive outthrow of blood from the ventricle in full contraction state, leading to enough space for expanding the atrial chamber. Blood continues to flow in the atria from the respective venous inflow tracts, and the atrial pressure begins to rise. The rise in the pressure continues until the atrioventricular valves open at the end of the phase 5. Now, this particular change in the phase you are seeing on the screen as well. Now, at the phase where the aortic and pulmonary valve open, it is approximately 200 milliseconds after the QRS complex and beginning of the ventricular contraction. The ventricular repolarization occurs as shown by the T wave of the electrocardiogram. The repolarization here leads to decline of the ventricular active tension and pressure generation. Therefore, the rate of ejection or ventricular emptying falls. Ventricular pressure falls slightly below the outflow tract pressure. However, the outward flow still occurs due to kinetic or inertial energy within the blood. The left atrial and the right atrial pressure gradually rise due to continued venous return from the lungs and from the systemic circulation. When the intraventricular pressure falls sufficiently at the end of the phase 4, the aortic and pulmonic valve abruptly close. The aortic precedes pulmonic, closing, thus causing the second heart sound and the beginning of the isovolumetric relaxation. Valve closure is associated with a small backflow of blood in the ventricles, which is a characteristic notch, also seen as incisura or dicrotic notch in the aortic and pulmonary artery pressure tracings, which you are seeing on the screen right now. After valve closure, the aortic and pulmonary artery pressure rises slightly, which is also shown as a dicrotic wave, followed by a slow decline in pressure. The rate of pressure decline in the ventricles is determined by the rate of relaxation of the muscle fiber, which is termed lucitropy. This relaxation is regulated largely by the sarcoplasmic reticulum that is responsible for the rapid regulated largely by the this particular sarcoplasmic reticulum is responsible for rapidly resequestering calcium, which is used in the previous excitation contraction coupling. Although the ventricular pressure decreases during this phase, the volumes do not change because all the valves are closed. The volume of blood that remains in the ventricle is called the end systolic volume and it is round about 50 milliliters in the left ventricle. The difference between the end diastolic volume and the end systolic volume is 70 milliliters and represents the stroke volume. Left atrial pressure continues to rise because of venous return from the lungs, and peak left atrial pressure at the end of this phase is termed the V wave. Now, as the ventricle, we can re-repeat it again as the ventricles continue to relax at the end of the phase 5, the intraventricular pressures will at some point fall between respective atrial pressures. When this occurs, the AV valve rapidly opens and passive ventricular filling begins. Despite the inflow of the blood from the atria, the intraventricular pressure continues to briefly fall because of the ventricles are still undergoing relaxation And once the ventricles are completely relaxed, their pressure will slowly rise as they fill up with blood from the atria. And thus the opening of the mitral valve causes a rapid fall in left atrial pressure. The peak of the left atrial pressure just before the valve open is the V wave. This is followed by the wide descent of the left atrial pressure. A similar wave and descent are found in right atrium and in the jugular vein. Ventricular filling is normally silent, so when third heart sound is audible during rapid ventricular filling, it may represent tensing of chordae tendineae or AV ring during the ventricular relaxation and filling. And this heart sound is normal in children but is often pathological in adults and caused by ventricular dilatation. Now, as the ventricles continue to fill with blood and expand, they become less compliant and intraventricular pressure rises. The increase in the intraventricular pressure reduces the pressure gradient across the atrioventricular valves, so the rate of filling falls in the late and the diastole. In normal resting hearts, the ventricle is about 90% filled by the end of this particular phase, and in other words, about 90% of the ventricular filling occurs before the atrial contraction, which is phase 1, and therefore is passive. And the aortic and pulmonary arterial pressure changes continue to fall during this period, and hence again the whole cardiac cycle repeats. Now this is the part of the cardiac cycle, and then we have to study the heart sounds which occur in this all phases of the cardiac cycle, which are the first heart sound and the second heart sound. The two heart sounds are normally heard through a stethoscope placed on the chest wall, and these sounds result from the vibrations caused by the closure of the heart valves. The first sound is associated with the closure of the atrioventricular valves at the beginning of the systole and is described as soft, low-pitched lub sound. And the second sound is associated with the closure of the pulmonary and aortic valve at the beginning of the diastole and is described as the dub sound. Now it is, here we will see it as lub dub, where the lub is low pitched and the dub sound is high pitched sound. In particular, to clinical correlation of this particular sound, there are many important things to remember that regarding the heart murmurs. Now, these sounds can be heard in any pathologic conditions of the heart, which will be called as heart murmurs. Now, the heart murmurs are the sound that usually result from the blood flowing past the valve of the heart. Most of these murmurs are not pathological, that is, they are not due to disease and are found in people with healthy hearts as well. So, however, sometimes some types of murmurs are caused by the flow of blood past the diseased valve. Heart valve disease may result from a defect which may be present at birth, or it may be due to other illness such as heart disease, rheumatic fever, heart attacks, or infection. So the two primary types of the heart valve disease are stenosis and insufficiency. Valve stenosis is a condition in which the valves are stiff or fused, causing a constriction in the size of the valve opening. This narrowing limits the amount of the blood that can flow past the valve. The valve insufficiency, which is also known as regurgitation, occurs when the cusp of the valve fail to close tightly and fall back instead of shutting completely, allowing the blood to leak through them. In mitral and aortic valve stenosis or insufficiency, the heart has to work harder to pump a sufficient amount of blood to the rest of the body. If these conditions are severe enough, heart failure can result. So when the valve is damaged or is very severely injured, the surgery is required to replace the diseased valve. Now a faint third and fourth heart sound may be detected as well, but they are not often heard in healthy adults. They usually are not related to valve sound but are attributed to the ventricular blood flow. Here we have to remember some key points that cardiac cycle is one complete heartbeat, which is a systole followed by a diastole. And during systole, blood is propelled out of the contracting ventricle into either pulmonary or systemic circulation. During diastole, the blood fills the emptied, relaxed ventricles, and the heart sounds result from the movement of the heart valves. And the first heart sound is due to the closure of the AV valve at the beginning of the systole, and the second heart sound is created by the closure of the pulmonary and aortic valve at the beginning of the diastole. And then again,
The murmurs are sometimes found in healthy person and mostly found in the pathologic diseases of the heart, such as heart attacks or stenosis or regurg or valve insufficiency. This part is very important to understand during a cardiac cycle and to diagnose where the valve incompetency has happened. Do like and subscribe if you like it. Take care and thank you.